Introduction. Welcome to today's lecture on Bell's palsy. In this lecture, we will explore the various aspects of Bell's palsy, including its anatomy, pathophysiology, clinical presentation, etiology, grading and classification systems, natural course and prognosis, management principles, treatment options, long-term sequelae, and recent research advances. Bell's palsy is a condition that affects the facial nerve and leads to weakness or paralysis of the muscles on one side of the face. Let's dive into our first topic, Bell's palsy. Bell's palsy is a form of facial paralysis that is characterized by the sudden onset of weakness or paralysis on one side of the face. The exact cause of Bell's palsy is not fully understood, but it is thought to be related to viral infection, specifically the herpes simplex virus type 1. The condition usually resolves on its own within a few months, but some patients may experience long-term complications. Bell's palsy affects both males and females equally and can occur at any age. To understand Bell's palsy, it is important to have a basic understanding of the anatomy and function of the facial nerve. The facial nerve controls the muscles of facial expression and also carries taste sensations from the anterior two-thirds of the tongue. It innervates various muscles, including the orbicularis oculi, orbicularis oris, and zygomaticus muscles. In Bell's palsy, the facial nerve becomes inflamed, leading to compression and subsequent damage to the nerve fibers. This results in the characteristic facial weakness or paralysis seen in Bell's palsy patients. Bell's palsy typically presents with the sudden onset of unilateral facial weakness or paralysis. Other common manifestations include drooping of the corner of the mouth, inability to close the eye on the affected side, drooling, and altered taste perception. The diagnosis of Bell's palsy is mainly clinical, based on the characteristic presentation. However, it is crucial to differentiate Bell's palsy from other conditions that may cause facial paralysis, such as stroke, Lyme disease, or tumors. Careful evaluation, including a thorough medical history, physical examination, and imaging studies if necessary, helps ensure an accurate diagnosis. Although the exact cause of Bell's palsy remains unclear, various factors have been identified as potential contributors. Viral infections, especially with the herpes simplex virus type 1, are thought to trigger an immune response that leads to inflammation and subsequent nerve damage. Other infectious agents, such as Epstein-Barr virus, cytomegalovirus, and respiratory viruses, have also been implicated. Additionally, certain risk factors, including pregnancy, diabetes, upper respiratory tract infections, and a family history of Bell's palsy, may increase the susceptibility to developing the condition. Grading and classification systems are essential tools for assessing the severity of Bell's palsy and monitoring its progression. One commonly used scale is the House-Brackman facial nerve grading system, which categorizes the severity of facial nerve dysfunction into 6 grades. Another system, the Sunnybrook facial grading system, provides a more detailed evaluation of facial movement. These systems allow clinicians to objectively assess the impact of Bell's palsy on a patient's facial function and guide treatment decisions. The natural course of Bell's palsy involves spontaneous recovery in most cases, with the majority of patients experiencing significant improvement within 6 months. However, a subset of individuals may have residual weakness or other long-term complications. Factors associated with a poorer prognosis include severe initial paralysis, older age, incomplete recovery within the first 3 weeks, and the presence of comorbid conditions. Prognostic factors help guide patient counseling and management decisions. Effective management of Bell's palsy involves a multidisciplinary approach, including neurologists, otolaryngologists, and ophthalmologists. The initial evaluation consists of a thorough history and physical examination to confirm the diagnosis and identify potential underlying causes. In the acute phase, protection of the affected eye and supportive measures, such as lubrication and taping, are essential to prevent corneal complications. Close monitoring and reassessment allow for timely interventions as needed. Corticosteroids, such as prednisone, are widely used in the treatment of Bell's palsy due to their anti-inflammatory properties. The administration of corticosteroids within 72 hours of symptom onset has been shown to accelerate recovery and improve outcomes. The exact mechanism of action is not fully understood, but it is believed to reduce edema and inflammation around the facial nerve. Corticosteroid therapy is generally well tolerated, but potential side effects should be considered. Individualized treatment plans should be tailored to each patient's needs. The role of antiviral therapy in Bell's palsy remains controversial. While some studies have suggested a potential benefit of antiviral agents, such as acyclovir, others have not shown significant efficacy. The decision to use antiviral therapy should take into account factors such as the severity of symptoms, the timing of treatment initiation, and the patient's overall clinical presentation. Further research is needed to clarify the role of antiviral agents in Bell's palsy management. Surgical interventions are reserved for certain patients with severe or refractory Bell's palsy. Facial nerve decompression surgery aims to relieve pressure on the facial nerve by removing bony or fibrous structures that may be compressing the nerve. Other surgical options include facial reanimation procedures, such as nerve grafting or muscle transfers, which aim to restore facial symmetry and function. The decision to proceed with surgery requires careful consideration and discussion among the patient, neurologist, and otolaryngologist. While most individuals with Bell's palsy recover completely or experience only mild residual effects, a proportion of patients may have long-term sequelae. These may include facial asymmetry, decreased facial expression, synkinesis, inappropriate facial muscle movements, and psychosocial impacts. The assessment of long-term sequelae is important for monitoring the patient's progress and identifying potential areas for intervention, such as physical therapy or psychological support. Ongoing research aims to further elucidate the pathogenesis, improve diagnostic methods, and develop novel treatment strategies for Bell's palsy. Molecular studies have identified potential biomarkers associated with the condition. Advanced imaging techniques, such as diffusion-weighted magnetic resonance imaging, may aid in the early diagnosis and differentiation of Bell's palsy. Additionally, emerging therapies, including immunomodulatory agents and regenerative medicine approaches, hold promise for enhancing recovery and reducing long-term complications. In conclusion, Bell's palsy is a condition that impacts the facial nerve and leads to unilateral facial weakness or paralysis. Understanding the anatomy, pathophysiology, clinical presentation, and management principles of Bell's palsy is crucial for healthcare professionals involved in its diagnosis and treatment. Advances in research and ongoing development of therapeutic interventions offer hope for further improving outcomes and the quality of life of Bell's palsy patients. As future physicians, your understanding of Bell's palsy and its complexities will enable you to optimize patient care and contribute to the field of neurology. Thank you for your attention, and I wish you success in your medical journey.